Good evening, everyone. Welcome to third session of critical care medicine classes, master classes. Today we have a case discussion on polytrauma. For that, we have seasoned examiners, Dr. Samavedam Srinivas sir. He is medical director from Virinchi Hospitals and faculty of critical care medicine from Virinchi. And he is a national executive committee member and secretary. And another examiner is Dr. Amarja. She is associate professor from St. John's Medical College, Bangalore. And we have our case presentation by Dr. Bharath. He's a final year DNB student from Continental Hospitals, Hyderabad. And another student is Dr. Melito. She is a final year DNB student from Continental Hospital, Apollo Hospitals, Jubilee Hills. Srinivas sir, please take over the mics.
So today, anyway, as we have already announced that this is a discussion about a patient with polytrauma. We will start with the presentation by Dr. Bharath, and then we can discuss the way this patient is resuscitated, the way the case goes forward, and what we can anticipate for this patient, as well as maybe, if time permits, a discussion about what all a candidate appearing for an exit exam, especially a DNB or a DM exam, needs to know vis-a-vis the management of a polytrauma patient. Dr. Bharath, please start.
Okay. So, good evening, everyone. I'm Dr. Bharath, and I'm going to talk on a case of polytrauma today. So, a 50-year-old male is brought to emergency room with alleged history of a road traffic accident at about 11 p.m. in the night. The mechanism of injury is a four-wheeler versus four-wheeler head-on collision, and he was immediately shifted to a nearby hospital where he was intubated in view of his threatened airway and low GCS, and C-spine is immobilized with a hard collar and shifted to higher center for further management. And he is received at our institute at about 1:30 a.m. in the night. So the primary survey, airway and the C-spine, airway is secured and C-spine is immobilized at the outside hospital. Then coming to breathing part, there is bilateral equal chest rise and palpation, chest compression test is positive. Airway is already secured and he is ventilating well and connected to invasive ventilation. Coming to circulation part, there is a rapid steady pulse with blood pressure of over 60 or 40 millimeters of mercury. And open injuries are there in the lower limbs where pressure bandages were applied, and they have applied a long limb splint just before shifting. And we have done an EFAST in the primary survey, which has showed positive in the right upper quadrant. Coming to disability assessment, on assessment of the GCS, his GCS is E2, VET, and M3, and pupils were about 3 mm, bilateral equal, reacting to light. And he is completely exposed and covered, and warm crystalloids started with warm crystalloid resuscitation. So 1 liter of crystalloid bolus was given, with which there is only a transient response in his blood pressure, which improved about 90 or 60 millimeters of mercury. And we have secured 2 large bore IV cannulas, and at the time of securing IV cannula, we have drawn a venous sample and sent for a VBG, which has showed a pH of about 7.04 and bicarbonate of 15.5. with lactate of about 9.96. So injection tranexamic acid was already given a start dose in the pre-hospital phase at the outside hospital. So we have started the infusion, and we have ordered for 2 type-specific PRBC and immediately started the PRBC transfusion in the ER itself. And catheters, Foley's catheter and voracasic tube has been inserted and is shifted to ICU with CT polytrauma on the way.
Dr. Bharath will stop here.
Yes, sir.
Can you go back to the previous slide? So when you are faced with such a patient in the emergency room, would you like some more information from the bystanders or the people or the ambulance crew who brought in the patient? Would you like to have some more information about this patient? What information would you like?
The mechanism of injury, sir.
Yeah.
And he being the place where he's sitting, whether the driver, whether he is restrained with a seat belt or unrestrained.
Yeah, so he's okay. Okay. Any other information would you like? Yeah. So, Dr. Melito, would you like to add something to what Dr. Bharath has already mentioned?
Yes, sir. As he already said, the mechanism, whether it is frontal, lateral impact, whether restraints were worn or not, and what is the damage that has happened to the co-passengers and also to the vehicle, like a bent steering vehicle or a windshield broken, can help us in knowing what to anticipate, what injuries have happened. Any damage to the dashboard will tell us about hip dislocation. So.
Yeah, so a couple of other points we need to understand. Has there been a death of a co-passenger is something that is very essential for us to know from the people who have retrieved this patient. That actually shows even if your external injuries of a patient involved in such an accident is not very obvious, he qualifies as a major trauma. That's the first point. Second, intoxication, exposure to alcohol or other intoxicating agents is also an important aspect when you take the history from bystanders, ambulance crew, police, or whoever has brought the patient. Loss of consciousness at the scene of the accident or trauma is also very important, as well as any involuntary movements noted and was any intervention done to control the seizures. What is the time of
Srinivas sir, okay, video, please switch on your video, sir. We are not able to see. Okay, sir. Go ahead.
Yeah. Second, the other point, very important point when you look at these patients is what is the time of extrication? How long has it taken for somebody to extricate this particular individual from the scene of the accident? Although it takes a lot of time in India, some of you may actually face Western exams also, even in this country. It is important because that is actually going to reflect upon the complications, the time duration of the shock which he had or he has at the time of presentation. So that brings us to the grading of shock. Dr. Melito, would you like to enumerate how a patient in shock is graded and how it influences your decision on resuscitating these patients?
Yes, sir. We would use Musler's classification described in ATLS, where it is graded from classes 1 to 4. In grade 1, there would be only narrowing of the pulse pressure. Then in grade 2, there will be tachycardia. When the patient actually presents with hypotension, he will be losing 30% of his volume, which is class 3 shock. And class 4 shock is severe hypotension, along with heart rate more than 110.
So what percentage of blood volume would have been lost between class 2 and class 3?
Less than 15% is class 1, 2 is 15 to 30, 30 to 40 is class 3, and more than 40% is class 4.
So how does it make a impact or influence? How does it have an influence on your resuscitation strategies?
Patients with class 3 shock would most likely require blood transfusions, sir, and class 4 shock would even require multiple transfusions based upon the mechanism of injury. So early information to the lab would help us to transfuse blood transfusions early and limit the amount of fluid resuscitation we give.
So Dr. Bharath, Dr. Melito said about fluid resuscitation. Would you like to list out the principles or the 4 points which we have to keep in mind while resuscitating these patients with fluids?
So we actually want to limit the crystalloids and start with the more of blood and blood product waste resuscitation, sir, to prevent dilutional coagulopathy.
Dr. Amarja, your opinion on this?
Yes, so in this particular patient, when the shock is so severe, so what will be your strategy in transfusing blood products? Is there anything you would like to consider for this patient?
We'll initiate a massive transfusion protocol with 1:1:1 ratio of fresh frozen plasma, random donor platelet, and packed red blood cells.
So why this particular ratio of FFP, platelets, and packed cells? Is there any evidence to use this?
Randomized. There are two randomized control trials, PROMPT and PROPER, which have compared fixed ratios and different ratios like 1:1:1 and 1:1:2, and they have said that the fixed ratio of 1:1:1 does not make. I mean, there is no mortality difference at 24 hours or 30 days if we choose 1:1:1 or 1:1:2. But if we go with 1:1:1, there is less mortality with exsanguination within the first 24 hours.
Yes. So in this particular patient, case of trauma, there are various causes for coagulopathy. When you start resuscitating, if you start giving crystalloids, there is a dilution of coagulation factors. And if you only give packed cells, there will be deficiency of coagulation
Clotting
factors.
factor.
Yes. So you need to use this particular ratio 1:1:1. And apart from that, I would like to ask one particular drug you have mentioned, tranexamic acid. So can you just tell what is the evidence for use of this drug and what dose you would like to use?
In crash through trial, they have actually tried 1 gram stat over 10 minutes. If the patient is reaching the center within 3 hours of trauma, and if we are able to give it within 1 hour, it is much more beneficial, and within 3 hours is beneficial. If we are giving more than 3 hours, it is harm more than benefit, which is 1 gram over 10 minutes followed by 1 gram infusion over 8 hours after reaching the hospital.
Yes, so this was one of the positive trial in critical care, crash through trial, which has shown benefit of using tranexamic acid. And if it is used within 3 hours of trauma, it has shown mortality due to bleeding was less. And the dose particular use was 1 gram initial dose, which was given in 10 minutes, followed by 1 gram given over 8 hours. So that is the role of tranexamic acid. But in clinical practice, what happens is we tend to continue this particular drug more than 8 hours, isn't it? Yes. And we need to remember that risk of thromboembolic complications in case of trauma are very high. This particular study also looked at any vascular events or thromboembolic events. When you use this particular dose, there were no any vascular events, and it was found to be one of the safest drugs to use. So there is a role for tranexamic acid in early treating these patients. Yeah.
Dr. Bharath, when you resuscitate these patients, what difference does it make whether if there was a penetrating trauma versus there was no penetrating trauma? How would your targets of resuscitation or your strategies of resuscitation differ between somebody who's got a penetrating trauma versus somebody who doesn't have a penetrating trauma?
So we have a scoring systems which predict us for early prediction of requirement of massive transfusion. Sir, one is TASH score and ABC score, which includes penetrating trauma as a component. Like if there is a penetrating trauma, the likelihood of requiring massive transfusion is more when compared to a non-penetrating trauma.
Dr. Melito, would you like to add to this?
Sir, actually, during resuscitation, the blood pressure goals for penetrating trauma and blunt trauma are different. As part of damage control resuscitation, we use permissive hypotension for both, but the recommended systolic blood pressure level is 80 to 90 mmHg in the absence of TBI in blunt trauma. It is 50 to 70 mmHg in the absence of TBI in penetrating trauma. We would be scared to pop the clot and increase the bleeding at high pressure levels in penetrating trauma.
Yeah, so that's the importance of your primary survey, where you would like to assess for life-threatening injuries, and penetrating trauma is always going to be a life-threatening injury during the course of resuscitation. Please continue, Dr.
So we have shifted the case, and we have done a CT polytrauma, which has showed in CT brain a small bifrontal subdural hemorrhage with no midline shift, and CT chest has shown a right pneumothorax with underlying lung contusion and collapse, with a grade 3 liver laceration with about 200 ml of free fluid in the abdomen. CT pelvis has shown left inferior and superior pubic ramus fracture with pubic symphysis diastasis and sacroiliac joint diastasis. And there is a right mid shaft femur fracture with right both bones leg fracture. So this is the CT lung as a part of CT scan polytrauma, which has shown a right pneumothorax with underlying lung collapse. So the patient is immediately rushed to ICU from the CT gantry, where we have immediately inserted ICD 30 French ICD into the right lung. This is a post ICD insertion X-ray where the lung has well expanded. And during this insertion, during this with the pneumothorax and all, there is further hemodynamic disturbance where we have already informed the blood bank to activate a massive transfusion protocol and ordered the blood and blood products in the ratio 1:1 of PRBC, RDP, and FFP. And because of the refractory shock, even with the 2 PRBCs that have been transfused in ER and 1 liter of crystalloid, we have started on vasopressin support of noradrenaline at about 5 ml per hour. And this is a reconstructed picture of lower limbs where there is a mid shaft of the femur comminuted fracture and both bones leg femur fracture, along with left superior pubic ramus and inferior pubic ramus fracture with symphysis pubis diastasis, and sacroiliac joint is also displaced. So by the time we have received the patient and stabilized with this ICD insertion and all, we had received the baseline labs where hemoglobin was 4.3 with total leukocyte count of 20.5, platelets of 1.5 lakh, and potassium was 2.5. Here APTT value is more than 120 seconds and INR is 4.07 with plasma fibrinogen of 96.
So before discussing about further management of this case, can you tell us what are the possible causes of hemorrhagic shock? What all injuries we have found, and what are the initial steps for management of these?
So at the site of injury, there is a small bifrontal SDH in the brain, ma'am.
Yes.
In the CT brain.
Yes.
Then C-spine is clear. No cervical spine injury. There is a right-sided tension pneumothorax, which is detected in the CT. Then a grade 3 liver laceration with right.
Yeah,
right.
Pneumothorax ICD has been already placed.
Yes, ICD has already.
Yes.
Then right mid shaft of the femur fracture and right both bone leg fracture, and there are open puncture wounds on the right and left anterior thigh and left anterior and posterior leg.
So one of the things you told is pelvic compression test is positive. So anything you want to do for this case?
Pelvic compression test, when I do a log roll, initially I'll see for any blood at the urethral meatus or any contusion or any blood from the urethral meatus, and a PR examination to see any high riding prostate or any bleeding through the rectum.
So any role of pelvic
binder? Of the sphincter.
Any role of pelvic binder for this case?
After doing this, I'll apply pelvic binder, madam.
And what should be the position of the binder?
It should be centered at the level of greater trochanterus.
Yes. So this particular patient had a pelvic fracture, and it was high likely that patient would have lost blood from these sides because a lot of iliac vessels would have got injured. So applying pelvic binder is a initial step to control the bleeding. And right side pneumothorax, you have already placed the ICD. On fast examination, you have found there is a blood in the right upper quadrant, isn't it?
Upper quadrant.
Yes. So anything you want to do for that?
As of now in the CT also, they have said that it is reported that there's about 200 ml of free fluid in the abdomen, possibly blood with the Hounsfield units. So I'll keep repeating the E-fast and see if it is increasing.
Yes. So basically it is a blunt trauma and it may not need surgical intervention, and you have to reassess the patient's condition, how he is responding with initial resuscitation. Okay. Yeah, you can continue.
So in secondary survey, there is no significant allergies or any past medications or past history, and he had food last meal at about 1 to 2 hours before the event. It is a high velocity head-on collision, and victim is an unrestrained driver, and the right lower limb is immobilized and splintered, with the right and left thigh is having open wounds with active bleeding where pressure dressing is applied and it is intact. Left leg has a punctured wound and pressure dressing is applied. And examination of back is done by doing a log roll. There is no step deformity or any external injuries that are noted on the back. So we have continued transfusing the blood and blood products at a rate of 1:1:1 ratio, and surface warming device is applied. In spite of the resuscitation, the vasopressor support has increased gradually over the night, and he even required a second and third vasopressor support in addition to the noradrenaline, which is adrenaline and vasopressin. So the labs which are repeated at about 6 hours later, hemoglobin was 4 with the platelets of 30,000, and creatinine has shot up to 2.1, and APTT is still high, more than 120 seconds. INR is about 6.89, which is still high, and fibrinogen there is further drop to 45. And ABG, which is repeated, has shown a pH of 7.22 with PO2 of 277, PCO2 of 29, bicarb of 14.9, with base excess of 14.4 and lactate of 10. And we have continued resuscitation with the same blood and blood products and not use any crystalloids. And
so, Dr. Bharath, at this point, when you want to transfuse blood and blood products for this patient, what are your points of attention? On what basis? Of course, patient is anemic, hemoglobin is low, so fractions will always be an integral part of your transfusion prescription. But apart from that, on what areas would you focus while deciding how much of what blood product would you give to this patient?
Ideally, if available, doing a thromboelastogram or any rotam, any viscoelastic testing would help us to actually identify the point where we need to concentrate more on about the blood products.
So what do you expect in this patient who has an APTT of more than 120, an INR of 6.8, and a fibrinogen of 45, and a platelet count of less than 50,000? What abnormality would you expect on the rotam or a thromboelastogram?
In a thromboelastogram, there will be increased R time and increased K time with the decrease in maximum amplitude. And
so how do you react to it? So when they for each of those interventions, how do you react as far as your decision to give a blood product is concerned?
So if the R time is prolonged, which is the initiation phase, there will be deficiency of the clotting factors, which we will supplement with the transfusing fresh frozen plasma.
Okay.
And if there is a prolongation of K time or alpha angle, which are actually the indicates the propagation phase from the initial clot formation to certain, so that is 2 mm to 20 mm, which indicates fibrinogen deficiency. So we have to supplement with the cryoprecipitate. So, and the maximum amplitude, which will tell about the maximum, the peak strength of the clot, which will indicate the function of the platelets. So if the maximum amplitude is decreased, which indicates either the platelet dysfunction or consumption, so we have to supplement with platelets. And if the lysis 30 time, that is the clot lysis after 30 minutes, if it is decreased, then it indicates that there is more lysis. Then we need to supplement with tranexamic acid or any antifibrinolytic agents.
Yeah, so amongst all the numbers you have mentioned, there is another number which we need to correct very aggressively for us to overcome this pyelonephrine. What would you think that is?
Base excess.
Yeah. So acidosis is something we need to be correcting aggressively in these patients.
And patient was actually hypothermic throughout, sir, despite we being hot air blowers and all, and giving, we don't have actually a fluid warmer to give a warm blood. The
Okay.
patient is hypothermic also.
So what is the best way of warming such patients?
One is hot air blower or
No, when the patient
Heat.
needs correction of acidosis and is also hypothermic, what is the best way of warming this? Initiation of a continuous renal replacement therapy where you have the ability to control the temperature of the circulating fluid is something you can initiate these patients. Okay. Please go on.
so we have repeated labs 6 hours later where HP hemoglobin has improved to 8.6, but and platelets to 60,000. But the coagulation parameters still remain low, still remain deranged. That APTT is still more than 120 seconds with INR of more than more than 5, and fibrinogen is 56. And repeated ABG shows pH of 7.25 with pH of 238 and pSWAT to 25.4, bicarb of 11, and base X is still -14 with lactate of 8. Throughout the course, the vasopressor requirement has been consistently increasing for this patient despite the blood and blood product based resuscitation. And
Interrupt here. This particular patient has not improved in spite of transfusing blood products. So is there any role for surgery or any other intervention you would like to do? Because hemoglobin is still low and his vasopressor requirement is still high.
We actually repeated EFAST time again almost every 1 hour or so, but we could not find any increase in the size of collection in the abdomen. So the long bone fractures have been splinted. Once he shifted to ICU, we have changed the splint to Thomas splint, applied a proper traction, and again the pressure dressings have all been changed. So we don't find any immediate surgical intervention.
Any role for angio to look for any vascular bleed or retroperitoneal bleed?
Yes, ma'am.
Because he had pelvic injury, and even after repeat fast scan, you didn't find any increase in the free fluid in the abdomen. So we need to find out any other focus for bleeding. And can you just enumerate what are the common sites for bleeding in case of trauma?
You mean the hidden sites which we usually tend to miss?
Yes.
One is pelvis, retroperitoneum, abdomen, and thorax.
Yeah, so sometimes scalp injury is also missed.
And scalp injuries, which we usually tend to ignore because of the distracting injuries lower down, can bleed torrentially.
So this particular patient, I'm not sure whether he was bleeding because of pelvic fracture or some basal injuries there.
No, actually, we have done an angio for this patient, but we could not actually make out anything, madam. Like apart from some small vascular change at the level of popliteal vessel, but even distal perfusion is maintained. So just small narrowing at the level of left popliteal vessel. We could not find out the exact source of bleed or any active leak of contrast anywhere.
Okay. Fine, continue.
So the left leg has penetrating injury on both anterior and posterior aspects. This pressure band has been applied tightly initially. So we felt some amount of tightening of the limb. So we suspected a compartment syndrome, and even we could not actually feel the pulse, probably because of the edema also. So we have done a CT contrast of the abdomen, and we have repeated actually. CT polytrauma was done along with the contrast. So here we have done a CT contrast of the abdomen again, and along with the peripheral angiography to see for any active vessel leaking. But we could not find out anything. So we thought there is compartment syndrome, and we asked the surgeon to do a bedside fasciotomy of the left leg. But despite the maximal vasopressor support and multiple blood and blood product transfusion, patient has sustained a bradycardia and asystole at about 12:30, and we have started CPR and tried for about 40 minutes, but could not revive. And we have total blood and blood products transfused by about 44 units, which includes 10 units of PRBC with 12 RDPs and 19 FFP and 3 sets of 3 cryo, which means 30 packs.
So this patient, when means, for example, for any case of trauma, if patient is requiring vasopressors, we need to be worried because per se vasopressors are not the primary treatment for trauma. We have to control the bleeding, so that is the primary treatment. And what do you think? What about? Can you mention about lethal triad of trauma? What would have happened to this patient?
Persisting hypothermia is there, persisting acidosis was there, and coagulopathy. The lethal triad, all the 3 components with the triad persisted from arrival to hospital till death.
Yeah, so when this triad sets in, very likely meant that the chances of improvement are less. So mortality is very, very high. So we need to prevent development of this triad. Okay.
So what could we have missed, Dr. Bharath and Dr. Melito, in this patient? We agree that we have done an angiogram, peripheral angiogram. We couldn't find a bleeder in the thigh. We couldn't find a bleeder in the pelvis, right? We couldn't identify a source of bleed, but the patient is bleeding. We ended up giving lots of transfusion, resulting in coagulopathy, and ultimately we lost the patient. So where could we have missed a few things in this patient?
In an unstable patient with a positive EFAST, taking the patient to the OT unless there is another cause, another obvious cause contributing to the hemorrhagic shock, because patient ICD has already been inserted, that cause of shock has been resolved. Abdomen and pelvis seem to be the cause. So taking the patient to the OR would have been.
So when a patient with multiple trauma presents to you with a tension pneumothorax, it also implies to you that his chest has sustained major injury. Okay.
So blunt cardiac injury.
What are the components of chest trauma which can kill a patient in hours? And what are the components of chest trauma which can kill somebody after 24 hours? Dr. Bharath? Dr. Bharath, are you there?
Yes, sir. Yes, sir.
Yeah. So in chest trauma, you found a patient with a tension pneumothorax, which means that obviously his chest also had impact, significant impact. What are the major killers of chest trauma within the first 6 hours? And what are the major killers after first 6 hours?
Tension pneumothorax and massive pneumothorax would be the major killers initially, sir.
Yeah, so tension pneumothorax, massive pneumothorax, open pneumothorax, and great vessel injury, and cardiac tamponade. These are the 5 major killers which kill a patient with chest trauma on site or within 6 hours of admission to the hospital. So when do you suspect that there has been a great vessel injury on chest trauma? What should make you suspect on imaging or clinical features wise? How would you suspect that somebody has got polythoracic great vascular injury?
In chest X-ray, usually we see a widened mediastinum with loss of aortic knuckle, and we can see a left apical cap sign with clinically widened pulse pressure.
Yeah, so in addition to that, this is one area where a normal chest X-ray, what we do as an APU, is good enough. If the diameter of the heart is more than 8 centimeters, right, in the pedicle, that means there is a vascular injury. As you said, apical pleural cap is an indicator. Widening of the carinal angle is a bad sign in these patients. And most importantly, if an orogastric or a nasogastric tube has been placed into the patient, displacement of the shad of the line of the nasogastric tube to the right is an important marker of great vascular injury of the chest. An open pneumothorax, how would you deal with an open pneumothorax? If somebody's got an open pneumo sucking air in with every breath, how would you deal with it?
We'll apply a occlusive dressing, which is closed on 3 sides and left open on 1 side, and we have to insert an ICD from a different side rather than the actual puncture. We have to insert ICD from a different side, ideally.
So, what are the causes of delayed precompensation after chest trauma?
Decompensation. One could be contusions, flail chest.
Both myocardial contusion and pulmonary contusion can happen. A flail chest can happen. And dissections of the subclavian vessels can manifest later at a different, at a subsequent resuscitation. So, when an individual is a restrained passenger in a vehicle and there is deceleration injury, seatbelt injuries have to be actively sought after. The passenger who is sitting in India, with the right side drive vehicles, the passenger who is sitting in the front would have a seatbelt that goes from the left to right. So a left clavicular injury, left secondary fracture, sternal fracture, cardiac injury, and liver lacerations should be actively sought after in a restrained passenger with a high velocity deceleration. Okay. A driver, on the other hand, is more likely to have the injuries to the spleen because the seat belt is restrained on the left side of the patient. So this examination finding should be actively sought after. So how would you suspect a pericardial effusion?
Pericardial effusion, we can suspect.
How would you expect? In this patient is in shock already. He's got hemorrhagic shock. He's probably got a myocardial depression because of acidosis. He may also have a tamponade. So how would you suspect?
So clinically, we can see with the Beck's triad, sir.
What is Beck's triad? Beck's triad is a combination of venous hypertension, arterial hypotension, and muffled heart sounds. This is a very late sign of tamponade, and usually once you find this is like your Cushing's reflex and raised eyes. So it's a very late sign. So your EFAST should be able to pick it up when you should actively see these injuries. So what are the drawbacks of EFAST? What are the injuries or collections which can be missed on an EFAST? Any retroperitoneal collections we can miss. Retroperitoneal can be missed. What else can be missed? We thought about pelvic collections can be missed unless the sonologist or the operator is very diligent. What else can be missed? Then any solid organ injuries cannot be greatly identified. Like any, Dr. Amarja?
Bowel injuries, if there is air, ultrasound cannot pass through air. So
yeah, one of the important things we should remember when we are doing the EFAST is that if there is extensive surgical emphysema, your interpretation of the EFAST becomes erroneous. So you should always be vigilant while passing a judgment on an EFAST made on a patient who's already got surgery. Okay. Dr. Amarja.
Yeah, so sometimes the EFAST can be suboptimal because of the patient is obese or the presence of subcutaneous emphysema. And when initial EFAST is negative, based on that, you cannot tell there are no abdominal injuries because the amount of blood in the abdominal cavity may be very less, maybe 100 ml to start with. And because of that, your initial EFAST can be negative. So the thing is, any deterioration in the patient's condition, we have to start with the primary survey again and look for ABCD and look for EFAST, repeat it and look for any change from the previous findings. So with you have to repeat E-fast when there is change in the hemodynamics of the patient. So that is important. And in case of retroperitoneal, definitely you cannot comment on retroperitoneal injury based on E-fast. So these are the limitations of using this. Bowel injury, as you told, bowel injury is also a limitation. You cannot tell there is no bowel injury based on E-fast.
So we are all talking about this term polytrauma and major trauma, Dr. Bharath. Is there any definition for a polytrauma? When do you call it as a polytrauma? When do you call it as a major trauma? So there are a couple of scoring systems called as the acute injury score and the trauma injury severity score. Based on these scores, you can grade a patient as severe trauma or major trauma. Apart from this, any injury, any single system or multi-system trauma associated with either a compromise of respiration or a compromise of hemodynamics or a compromise of cerebral perfusion or sensorium is categorized as severe trauma or major trauma. In addition, trauma in the elderly of any age above 65, trauma in a pregnant lady of any period of gestation is considered as major trauma. And as I said before, trauma involving a situation where one of the passengers or one of the people traveling in the vehicle has succumbed to trauma on site. All the passengers are considered to be victims of major trauma. You need to make a diligent examination of all these patients. So Venkat?
Sir, we can take few questions if you see the chat box.
So let's see the chat box actually. Dr. Ashima Sharma has a lot of learning lessons for us. I think we should read them. Can she speak, Dr. Venkat?
Yeah, we can unmute, I think.
Yeah, just can you allow Dr. Ashima to speak?
Pawan, can we unmute Dr. Ashima?
Dr. Ashima Sharma, please.
One moment, sir.
Okay.
Dr. Ashima is a professor of emergency medicine at the Nizam Institute. So she is probably experienced a lot, must have seen a lot of these situations. So we can learn from her as well. In the meantime, let's see a few questions if we can answer them. Is there any contraindication for the use of vasopressin in trauma patients? Gut ischemia can worsen. Myocardial ischemia and contusions can worsen, but if there is no choice, you have to use it to defend the vena arterial pressure. Pneumo should have been picked up in primary survey, point taken. How to rule out cervical spine injury based on the GCH and other distracting injuries? The Canadian C-spine rule can be used if the patient is upturned.
Please go ahead, sir.
So Canadian C-spine rule, the Nexa criteria can be used both for thoracic trauma as well as for C-spine. So a lot of this factor 7 is slowly losing its place in the management of trauma, except in patients who have significant inoperable liver injury and documented factor 7 related clotting deficiencies. Otherwise, it is prothrombin complex. Yes, it must be considered in these patients who are refractory to the other methods of correction. Whole blood transfusion doesn't make a difference. Also, there's a comment in this age of head to toe CT. Is so much detailed history regarding extraction time, seatbelt use. Important time is gold in trauma. On basis of history, anyway, we don't rule in or rule out anything in trauma. It is just a practical query. Point taken, but when you know the history, you will look for certain things. When you don't know it, some life-threatening injuries can only be unearthed during secondary hip survey, by which time the match would have been over. When patient continuously has falling fibrinogen and low hemoglobin, in spite of transfusion, still we should go with 1:1. No. When a particular factor deficiency is noted, you will need to know the correction factor and give as many cryos as needed. You don't stick to the 1:1 of FFP once you know that there is a deficiency of one of them. Do we have Dr. Ashima online?
Pawan, can we
No, sir.
unmute Doctor? Okay. Sir, for the audience sake, there was a discussion on use of a ROTEM or a thromboelastography.
Yes.
What is the actually positioning of this test? When do we actually ask all trauma or a massive transfusion when indicated?
The typical situation, as somebody said, when your hemoglobin is falling, your fibrinogen is falling, and your 1:1 strategy isn't working, that's when you should actually look at ROTEM, but its availability is an issue. If the center has a ROTEM on the premises, it's always better to do a ROTEM. But if it's present in some other center, sending it there and getting it done is not going to achieve the purpose, because the processing time has to be very quick for the ROTEM. Any role of colloids as a part of fluid resuscitation in trauma, the Albayor study clearly has shown that if brain injury is a part of the trauma, then albumin probably is detrimental. As a resuscitation fluid, albumin is not recommended. If you're talking about other colloids, starch is definitely not recommended in trauma resuscitation. So we won't probably be preferred. It's probably crystalloids and blood products that form the basis of resuscitation in trauma.
Choice of crystalloid.
Sorry?
Of crystalloids. Choice of crystalloid.
Crystalloid. Choice of crystalloid. Choice of crystalloid. Okay. So initially on the scene, any crystalloid you can get, preferably saline. Although there is a risk of producing hyperchloremic situation. Once you have crossed the 2 liters of saline, it's not a very bad thing to use. There is this concept of ringer lactate causing hyperkalemia, but it's not, unless somebody is actually rhabdo and having a potassium of more than 6, then RL may be detrimental, and it does not actually worsen your lactic acidosis. So don't no worries with lactated ringers, but balanced salt solutions, if your resuscitation is ongoing, balanced salt solutions may be preferable. Role of bicarbonate.
Yes, sir.
Role of bicarbonate for correcting acidosis. The BICAR ICU study did not include a big number of trauma shock patients. So in trauma shock, the role of bicarb in correcting acidosis is very limited, unlike septic and other patients with acidosis. So it may actually give you a false sense of normalization of the blood gases. So unless you are pushed to the wall, there are life-threatening arrhythmias when you are unable to correct it with extracorporeal techniques. Maybe it's not recommended. I would like Amarja also to comment on this.
Yeah, so bicarbonate, definitely there is no role, because we have to treat why the patient is having metabolic acidosis. By giving only bicarb, we are worsening the intracellular acidosis. There is no role. And we, especially in trauma, even patient requiring renal replacement therapy and all, means already lethal triad of trauma has set in. So we have already missed the bus.
So, sir, any role of this learning about the triads, what the emergency team always execute when there is a mass casualty? It has been a common situation. Sometimes you get a surge of cases with a mass casualty. So classifying the cases, they triaging them, role of intensivist in assisting the emergency team.
Yeah, so the intensivists here are people who will guide the resuscitation, who can manage life-threatening problems like tension pneumothorax, cardiac tamponade, flail chest, open pneumothorax. The intensivist can step in. Difficult airways, definitely the intensivist have to step in. If you can't intubate, getting us a cricothyroidotomy in, the intensivist have to help. Will be useful. And of course, the other management of acidosis, hypothermia, and all can be coordinated by the intensive care guys, while the emergency medicine guys are actually prioritizing the patients, identifying those who need immediate surgical intervention versus those who need immediate imaging. Will be the realm of the emergency room, team guys. The anesthesia team, yes, the airway accesses and the airway stabilization will be the realm of the anesthesia team. So it's a multi-system, multi-department, multi-specialty focus. So the mass casualty.
What questions we expect in exams are related to this difficult airway and C-spine related stability questions in this trauma situations in exam point of view?
Yeah, so how to stabilize the C-spine, what type of collar you use, what is the difference between the soft collar used for cervical spondylosis versus the Philadelphia collar. How do you get an emergency airway access in somebody whose C-spine has not yet been cleared? Intubation of these patients, how do you do inline neck stabilization? Of course, ventilatory strategies in patients who are having traumatic brain injury. What are their ventilation strategies? How do you keep a tab on the carbon dioxide without hyper and hypoventilating these patients? Are some of the questions you can expect. One of the mistakes which candidates in their enthusiasm say is that if you can't intubate, you will do a percutaneous tracheostomy. Now that's where you get into trouble, because you cannot do a percutaneous tracheostomy with all the maneuvers and manipulations involved in it in a patient whose C-spine is already unstable. So we should keep away from using that term in an exam. Of course, surgical emphysema. What happens if there is an unstable mandible and how do you manage it is something that is often asked. Would you use NIV if somebody has got trauma and has got flail chest? Would you put NIV on somebody who probably has subconjunctival hemorrhages? Would you put NIV? The answer is no, because you haven't yet excluded the orbital fractures and roof of the orbit fractures. So these are some of the things as far as the C-spine stabilization and airway is concerned.
So there are questions related to DPL, role of DPL in this trauma cases.
DPL is no longer recommended by the ATLS and other trauma societies. With the advent of EFAST and CT scans, they are doing away with DPL. So,
role of ionized calcium in massive transfusions in trauma cases. I'm just reading out the questions.
yeah. So, Amarja.
When the number of blood products we are giving are more, likely that it can reduce calcium. So when blood products more than 3 to 4 paxils if we are transfusing, we need to keep watch on calcium as well, because that also can affect the coagulation cascade and can result in coagulopathy. So keeping normal ionized calcium will be the target, maybe 1 to 1.5, 1.5.
So there is the questions related to auto transfusion in these situations where we do not have a facility to have any of the bloods available. And what about the choice of blood grouping in them in this kind of a major trauma or hemodynamic unstable patients. Amarja, grouping and the universal donor role here.
Transfusion, if you look at the Indian scenario, it may not be possible to use this strategy. Depends upon the center where this can be considered. We cannot generalize.
Srinivas sir, the
Yeah,
transfusion,
the center should be expert in doing auto transfusion. It's easy for us to see in the movies that the hero comes in, donates blood, and the blood goes up against gravity and then descends into the patient like water falling from a dam. It's good to see and have a laugh about it on the movies, but it doesn't happen in the bedside in an ICU or in an emergency. So,
operation theater.
No, it's technically challenging. You need to have that separator online going, and then it has to be the center doing it has to be technically very skilled, and the personnel have to be available. It can't be done just by having either the equipment or the people. You need to be trained, and it should be like a well-oiled machine. You should be doing it regularly. Very, very few centers have that capability of doing auto transfer.
So the grouping and universal O negative transfusion or groupings and specific transfusion in this emergency situation, sir.
Yeah, so O negative definitely the way to go if you have no time to match and give. If your blood bank or your whatever you have access to a blood bank which has enough O negative, no harm, you can give it, but try to get in the matched products as soon as possible. No harm with O negative, you can try, no issue.
Any light on the sternal injury, sir, as you pointed out when the sternal fractures and
yeah, so in a seatbelt injury, if you have a sternal dislocation and mobility, that means the lower 2/3 of the sternum moves independent of the upper 1/3 of the sternum. That is, the angle of Louis is not intact. Then technically you can expect several injuries. You can expect starting from aortic root injury, you can expect a carinal injury, you can expect an esophageal tear, you can expect thoracic duct injury, because these are all anatomical structures related to the angle of. So if your sternum is unstable, even if there are no flail segments, two things will happen. If your sternum has fractured, then your chest has lost its synchrony. Your chest, will not. Both sides of the chest won't move in synchrony. They will be dissociated. In addition, if your angle of Louis is injured or fractured, then clinically you should suspect all these injuries: thoracic duct, the root of aorta, carina, and esophagus. So if this patient has a cervical emphysema or a tension pneumothorax, while the lung pleura may be the source of the tension pneumothorax, also look at the trachea and the esophagus as the cause of a tension pneumothorax.
So there are a lot of curiosity related Ribova.
Yeah, Ribova is still not available in the majority of the centers. A few specialty centers are using it in this country, but it will come sooner or later.
So I think, sir, you can just take all our students through the flow, sir, from beginning, which are the things as an examiner you will expect them to know, and probably Dr. Amarja can add later on, and we can conclude the session, sir, from starting.
So when you have a patient with trauma, always make sure that you approach the patient systematically. Head to toe would mean head to toe. No jumping. There may be a distracting injury somewhere else, but the primary survey has to be meticulous. All the components of primary survey you have to be perfect with. What are the components of EFAST? What windows would you use? What are the injuries which can be picked up by EFAST? What are the injuries which cannot pick up with EFAST? You should be able to remember. If you have a patient who's got a component of traumatic brain injury, what are the components of resuscitation which are different in traumatic brain injury from polytrauma without traumatic brain injury? What are the indications? I'm sure there would be another session on traumatic brain injury as part of this series. But always remember the indications for CT in a patient with traumatic brain injury. Not all patients warrant a CT. There are definite criteria for doing CT. Components of one thing we forgot to discuss as a cause of hypotension in these patients is abdominal compartment syndrome, especially if these patients have had large volume fluid and blood resuscitation and blunt trauma abdomen, especially if there has been a liver injury in this patient. So keep all your information about when do you start measuring intra-abdominal pressure in these patients, what are the different categories of intra-abdominal hypertension, what intervention to do for what stage, what are the components of luminal decompression, extraluminal decompression you should be aware of. We have discussed in detail about the coagulopathy of trauma shock, the lethal triad of coagulopathy. The entire sequence of coagulation cascade you should understand. The final common pathway you should be able to remember. Principles of ROTEM, interpretation of tests of coagulation, indications for interventional radiology and vascular embolization, what caliber of vessels can be accessed by an interventional radiologist and what cannot be done, pros and cons of using tranexamic acid in trauma. Most importantly, quite often you'll be asked about management of pulmonary thromboembolism in trauma, especially if a patient has got pelvic trauma and then you have given tranexamic acid, and the patient, the case scenario might progress to hypoxia with normal lungs and the right ventricular strain pattern and abnormal TAPC. So the question will be asked, how do you manage the pulmonary embolism in trauma? And there may or may not be questions about the use of an IVC filter. What is this role of IVC filter in trauma and anticoagulation? For patient with major trauma who's undergone surgery, when do you start DVT prophylaxis and with what do you give DVT prophylaxis? Mechanical versus thromboprophylaxis, we should be careful about. Fluid resuscitation, I think we have discussed. Antibiotics, feeding in trauma also is an important issue. Role of immunonutrition in trauma would be asked. I'm sure it would have been discussed when we discussed about burns, but even in trauma, this is something you would be discussed. Dr. Amarja.
Yeah, we have already summarized all the details. One thing is when there is when we shift the patient from emergency to ICU, there is a particular way we hand over the patient. So MIST protocol, that is mechanism, injury and signs and symptoms and what treatment is given so that we don't miss any injuries and there will be continuity of care. And apart from that, I think Dr. Srinivas has already mentioned all the details. So more and more if we practice how to do primary survey or secondary survey, because majority of the times after initial stabilization in the ER, patient comes to ICU. So we don't have practice on how to actually do primary survey, what are the, how to do EFAST, how to identify structures, because placement of the marker is the key thing. If we place it wrongly, we can't identify abnormality, and how to identify presence of blood on ultrasound. All this, if we practice, then only we will be able to do in the exam. And placement of the cervical collar, how to do log roll. So all these things will be asked in the exam.
Over to you, Dr. Shashidhar, over to you.
It's a very nice and interactive session. Even from audience, we have a lot of comments and questions. So I think all the questions were answered. I thank Dr. Srinivas sir for taking out his time in his busy schedule and giving us. And I thank Dr. Amarja for giving us time. And I thank Dr. Bharath and Melito for getting an interesting case for discussion. Thank you. Next time we will meet with another case.
Thank you, Dr. Melito and Dr. Bharath. All the best for your exam. Be calm, be confident. This is not a challenge for you. Just see, approach the exam as I would approach a patient in the emergency room. So don't bother about the examiners, what they're thinking. think what you would think as a consultant, and you will get through. I'm sure both of you will do well. All the best. Okay.
Thank you, sir. Thank
Thank
you.
you, sir.
Thank you, sir.
Thank you, Dr. Amarja. Thank you, Srinivas, sir.
Thank you.